I'm the chairman of this session, special session sponsored by Nestlé. And I'm Guy Letellier, and I'm a pediatrist and a PM&R specialist working in Nantes, just the other side of France, near the Atlantic Ocean. And I'm just happy to be with you, honored to be invited as well with my two colleagues who I will represent in a few seconds. I have just an introductory talk to tell you a little more about nutritional issues and needs in children that we all know. I don't know if everybody's really familiar with the children, toddlers and young infants and adolescents. We will try to browse all these kind of different persons. And of course, the perspective of this talk is to have some literally dynamic exchange afterwards and try to finish on time because well, there were some technical issues this morning. I thank Nestlé for inviting us, of course. And might be some repetitive information for you, but the children that we deal with and who do have nutritional and dysphagia have already very severe motor impairment, any kind of encephalopathy, and the experience of feeding difficulties. This risk of malnutrition is even greater when there are swallowing deficits as well, and usually both of them are in the same way. These causes of dysphagia, I mean, you would also, Karen, talk about them later. All the TBI are really at risk. Some neurological disorders I will try to define afterwards. CP, like with premotor, but not always just that kind of condition. Tracheotomy, ventilator dependence, that was one of my big issues when I worked near Paris, and the failure to thrive. Left and grief, you know about her, like the queen of dysphagia, taught us much about it. And recently that review marked by Askay Batra is really interesting to overview all these kind of situations. So, who are they? Let me speak to you about these kind of literally lovely patients we had for a couple of days, sometimes weeks or months. With here the 4 months old enabled encephalopathy, with the mother trying to stimulate the mouth with a finger first, never with the spoon first. And here another little child with 20 months old, this kind of encephalopathy that has spinal osteodysplasia, microretrodogmatism, and this posture that has eventually, bad condition for swallowing because of the brace. That little child is 5 years old and has never eaten before that sequence. The first time she puts something in her mouth and tries to swallow it. And there's the real empowerment of the mother, try to make her tasting textures. We will speak about this later. And there's a major interest in installation as well. And she has a mirror in front of her, trying to have a feedback. Unlike her vision problems that are somehow over handicap for her. Maybe I can skip this a little bit. Here we have a strong guy. He's 16 years old and he lost more than 15 kgs in 4 months. There was a real nutritional issue. And before standing here, we tried to, with his multiple stroke, cognitive, attentional, and practice disorders, with his hemineglect, try to empower his entry with adapted utensils. So here in France we have the OT, occupational therapist. Might be different in some other countries, trying to figure out how he could use his own spoon and try to be a little more concentrated on his yogurt, for instance. And as I pass quickly, she's very smart, but very impaired with her, her this her tune, her tune that gives her some invasive movements, and she even has been hospitalized because of pneumopathia, like many of our children. So I'm talking about children, but she's 19 years old. So there's a very big challenge to make them have a good transition between the pediatric years and the adulthood. So, 2016, so it's not that, it's already old now, but we know that GMSs, you know how we convinced people to put the people in some strategies to handle them. GMFCS1, the less impaired motor function level, until GMFCS5. And we know that the first one, who are almost as tall and as well nutritioned than the typically developed children, are taller than the one who have bigger impairments. That's obvious, but it had to be seen and to be matched. And Christy Bell in 2017 in the ESPGHAN told us about it. And were risen again last year's couple of experts who tried to figure out how come that we have some feeding and swallowing issues, and the red flags that Joan Arvidson rose up a few years ago were really something special, that even pediatrists who are not really used to deal with people with severe impairment could ask some very easy questions. How does it look like to feed your child, and are the meal times stressful? Is your child gaining weight adequately according to you? And are there any respiratory signs? Okay, and of these conditions, Christy Bell again and her fellows in Australia tried to look after some questions that really were remarkable and could be used by giving a score that gives the right path afterwards to be followed by the physicians, the nurses, the dietitians, to assess them more adequately. Within these 4 questions, do you think this child is underweight? Is it gaining weight? Do you think the child has any problems with eating comparing to other children? And do you think the child has drinking problems? So we have that nutritional issue and the swelling issue as well in some tiny questions. That's the base of some reflection that Professor Numur will discover. So what do they need actually? Some fluid, of course, to be hydrated, and some kind of modifications for these preschool children with CP. They have to take on some energy, of course. What kind of energy? We'll see that further on. We have the more gross function is impaired, the less chewable items you can ask them to put in. So there's a real problem around texture. You have to know that some mobility issues could rise up, some metabolism demands. We need some muscle activity to be really taken into account, like dystonia we saw before, and trying to catch up and maintain that staturoponderal growth. 2 to 2.5 grams per kilo per day for proteins, okay? And low formulas could be easily taken, but with the intake of fluid for better hydration. So try to enhance nutritional status, this kind of malaise of malnutrition that many people have, and we made a small scope in our wards. About 10% of the children are almost malnourished, even in France. Try to keep on the strength of the child to be able to pass through the rehab center and the psychomotor development. So, again, feeding support is less in point per children and is raising up to 90% for GMFCS5. We ran a small retrospective study, but well written because it was in Montreal, a very nice dysphagia clinic around a multidisciplinary team like we are today, with the PM&R specialist, OT, nutritionist, physiotherapist, and radiologist to pass children through VFSS. We talk about this morning, and we'll talk about it later. So 200 patients, and what's interesting that most of them, well, had intratracheal aspiration, and 100% children with neurodisabilities have swallowing issues. Okay, not all come up in the ICU, but it's a real severe condition. So we have to assess them. What take-home messages? Detect them, have good positioning, nutritional support, try to enrich up their internal nutrition, and of course selection of texture if something orally can be taken. And the ESPGAN has good items to help us to remind that micronutrition is important, sure, but we have to have growth charts, and even for pediatrician, trying to have a real good height and weight is something challenging inside our wards. And the latest recommendation can be found on this side, of course.